So good morning. Good morning, everyone. And my name is Prabhakaran Dorairaj. I'm a cardiologist and an epidemiologist from India. I am president-elect of the World Heart Federation. So today we are going to discuss some of the challenges and opportunities that we have because of the COVID-19 pandemic. So we all know that the COVID-19 pandemic really disrupted healthcare, particularly the workforce. We lost some of the workforce. We, uh, both in terms of the disease as in terms of job opportunities and things like that, it completely disrupted the healthcare. So today we have a set of great panelists. We have Yvonne Commodore Mensah, who is a cardiovascular epidemiologist from the Johns Hopkins Bloomberg School of Public Health in the United States. And we have Demilaid Adedineshwo, sorry for the, and she's a cardiologist with interest in AI, and she's from Mayo Clinic. So essentially what we are looking today is how to look at the evolving landscape of cardiovascular health services and explore some of the strategies to address immediate workforce gaps, but also build some of the sustainable systems for training, supporting and retaining skilled professionals. So the whole idea is that if you have another epidemic like this or even otherwise, how do we make the cardiovascular healthcare more sustainable? That's the question. And we are posing three things. So first is to assess the impact of COVID-19 on cardiovascular health workforce and identify some of the lessons that we have learned from this pandemic. The second is to explore the strategies for workforce retention and policies that support healthcare professionals. The big problem is mental and physical well-being. We looked at the burnout and all that, and how to foster a sustainable and equitable workforce. The last, of course, is the big thing now, which is digital health and AI. How are we going to look at some innovative models of care using some of these strategies? So we will have an informal conversation. Maybe what I can start with you is Yvonne, is what do you think, I mean, how has the COVID-19 pandemic affected the mental and physical well-being of healthcare workers? And what do you think can we do in terms of making, healthcare resilient?
First of all, I'm so grateful that the WHF gave me the opportunity to be here and to share the stage with one of my dearest colleagues. And I'm also grateful that we're having this conversation 5 years after the COVID-19 pandemic started. One could say, well, this is behind us, let's move on and plan for the future. But the reality is that there are still health systems that are reeling and trying to recover from the pandemic, and so there are lessons we should learn. And prior to the pandemic, we know that the health workforce, whether it's nurses, physicians, you name it, experience very high levels of burnout, right? So these issues regarding burnout, anxiety, stress, depression, there are estimates that suggest that 1 in 5 healthcare professionals may be depressed, right? And these issues predated the COVID-19 pandemic. So how do we truly recover from this? I think one of the things we should not do is to say, well, healthcare professionals should be resilient, right? And I know throughout the COVID-19 pandemic, we talked about, resilience, but I think it's important that we move the conversation further and consider how to address systemic issues and institutional issues that may contribute to burnout, stress, anxiety, depression in healthcare professionals. For instance, how do we address issues surrounding safe staffing and understaffing of our healthcare systems, right? So if you have a unit and it's understaffed, you don't have enough nurses, physicians, it's not enough to say, well, consider some meditation, yoga, all of these things are important, but we still need to address some of the systemic issues that affect healthcare professionals and invest in people, right? And also for leadership to acknowledge that it takes people to run these healthcare systems. And because I'm also a nurse, I would be remiss if I didn't acknowledge that when we look across the world, nurses make up the majority of the health workforce. And when we think about interventions to boost the healthcare system and address stress and burnout, we should not forget nurses. And we should not forget the roles that they play in terms of advancing health and also invest in the nursing profession as well.
Thank you. I mean, that was a very elaborate, comprehensive answer to the question that I asked. And I think we'll come back again. But before that, I wanted to ask you, Demi, is, you know, AI is the big elephant in the room. What do you think, how do you think AI is going to change cardiovascular diagnosis and healthcare? And what do you think would be the future of AI in terms of cardiovascular healthcare?
Thank you so much, and I appreciate that question. So there has been a lot of hype surrounding artificial intelligence, and I think it's getting to that point where people are waiting to see exactly what impact is it going to make. So far, there's a lot of evidence. We have a lot of published manuscripts that is showing the potential for artificial intelligence to transform how we provide care to patients. In the field of cardiology specifically, we have novel tools now that can take data from some of the existing diagnostic tests that we have and essentially supercharge this test so that we are able to make better diagnosis for our patients, earlier diagnosis. And I'll give you examples. Right now, we know that you can take data from an ECG, which is a simple 10-second electrical recording of the activity around the heart, and you can predict the likelihood of whether a patient has cardiac dysfunction or whether they have structural abnormalities like cardiac amyloidosis, whether they have valvular heart diseases. Normally, all of these other conditions require additional testing, sometimes expensive testing, and require skilled people to also do this test, like getting an echocardiogram or an MRI or a cardiac biopsy. But the fact that we can leverage simple tools like an ECG to be able to improve diagnosis has huge, tremendous potential for how we can identify patients early. Now let's bring this to environments that lack access to specialists or access to advanced diagnostic testing. This could be a game changer for them because now we have the opportunity to bring diagnosis to areas that maybe otherwise would not be able to get the diagnosis for this condition. But we now have to start thinking about moving forward. How do we implement some of these AI tools? And are these tools going to be equitably implemented? Are people actually going to see the benefit of it? Will it improve outcomes for our patients? And that's something that we can continue to discuss.
Right. I think you are bang on target saying that resource constrained settings could use some of the advances in AI, particularly in avoiding very expensive diagnostic tests. So that's great. You answered some of the questions which I'm going to ask earlier, but I just want you to elaborate a little bit more on specific critical challenges that we are facing in cardiovascular healthcare.
One of the challenges I think I highlighted earlier is a shortage of healthcare professionals. And I also want to focus on low and middle income countries as well, because we know that a lot of countries invest in training physicians, nurses, and other health professionals. And what happens because of a number of reasons, including unsafe working conditions and the desire to seek greener pastures and better socioeconomic status, you have what healthcare professionals migrate to places like the US, the UK, in pursuit of a better life. And sometimes the impact on that and the local health systems is something that we should also acknowledge. And we also know that there's a mismatch between the burden of disease and availability of healthcare professionals. So whether it's in the US, Europe, we know that, and even in low and middle income countries, we know that there are people in rural areas who need advanced cardiovascular care but don't have access to cardiologists and other specialists. So how do we bridge the gap and make sure that regardless of where you are, we can transform healthcare for all? And so the other thing I'll also highlight is a lack of diversity in our health workforce. And I think this conversation comes at a time when a lot of initiatives to increase the diversity of the health workforce in the US is under attack. There are trainees who are receiving funding from diverse backgrounds who've lost their funding to become cardiovascular health researchers. And this is happening as we speak. So it's a critical issue that we need to address because we know that populations that suffer disproportionately from heart disease, Black, Hispanic, and other, and
Yeah.
Native American populations, we need to double down and improve their health outcomes. But unfortunately, we don't have enough healthcare professionals that represent these groups. So we need to continue to invest in improving the diversity of our health workforce as well.
So, do you think this brain drain, as you're calling, is one of the biggest challenges for LMIC? But do you think it's an opportunity because there's a lot of cross learning, there's collaboration, and there's also now reverse brain drain, people going back. So, what do you think of that?
Now, this is one of my favorite topics. So I talked about brain drain. And so we have what we call brain gain. So there are different ways to look at this issue. Yes, people may leave for different reasons, but they are still connected. They still have deep roots. So people like Dr. Prabhakar, you have ties to your home country. And so I imagine what will happen if, let's say, 25% of the diaspora community, whether you're African, you're South Asian, and you've trained in the US and Europe, and you make a conscious decision to take your talents back home and collaborate and support the colleagues back home, that makes a world of difference. So we actually started a nonprofit, an African diaspora nursing nonprofit, to do exactly that, to mobilize all African diaspora nurses around the world to invest in capacity building. So we offer webinars, we offer conferences, and one of the amazing things is when a nurse walks up to you and says, wow, I've been reading about this person in the literature and you brought them to Ghana, right? And so it really makes a difference. So I'm glad that you highlighted that there are two sides of the issue, but we also need to address the structural reasons why people leave in the first place, right? But if they do leave, there are ways to re-engage with them to build capacity in those countries.
So the world has become very interconnected, and also the desire to give back to your communities, to your countries, is very strong. And I think it's not so much of an issue as it was in the later part of the 20th century when there's a huge brain drain to Western societies. Now I think it's kind of helping people to assimilate, to cross-pollinate ideas and knowledge, and therefore I'm not saying it's a win-win situation, but it's getting there, right? So Demi, how do you think AI-driven solutions can help workforce enhancement and improve efficiency in cardiovascular healthcare?
So that's a great question. And I kind of alluded to this about so many tools already exist that is showing efficacy. Okay, this tool works, but then now we need to start to measure what is the impact of these tools. And I know there's studies out of the United States that is already showing that the use of some artificial intelligence tools that can help reduce the workload on physicians is already showing positive outcomes where physicians are reporting that they are spending less time charting, spending less time, in the electronic medical records, which improves their efficiency, and it also improves burnout for them because they feel better because they're able to complete their work in a timely manner. There's also other studies that has actually assessed the impact on the patients, like how do the patients feel when they're using this efficiency tools. And one of the examples is ambient AI that is able to listen while the physician is having a conversation with the patient, so that instead of the physician spending time typing glued to a computer, they can actually listen, engage with the patient, and have a conversation with them. And at the end of that encounter, within a few minutes, the note is automatically generated. And patients feel a better connection to their physicians as well, and already seeing benefit from this. Unfortunately, there is limited information about how tools like this will improve efficiency, care, and burnout for providers in low and middle income countries. First, there's a challenge with electronic medical record systems in many low and middle income countries who have not yet integrated with digital tools. So they still use a lot of paper records, and then it makes you wonder, will tools like this actually improve efficiency in low and middle income countries? Maybe not, because they are not fit for that purpose, and we have to start to think about solutions that would enhance care in those settings. Otherwise, there are other things that can be deployed. Things like telemedicine is now providing access to specialist care for people in these areas or in regions where they might not even have access to any of this specialist care. They can connect with specialists from anywhere around the world. Like you talked about, medicine and healthcare being generally interconnected. So they can leverage that. And there are some countries that are also leveraging this hub and spoke model where they have specialists in the bigger cities, but maybe not in the smaller villages and the smaller cities, but they can connect to them either via video conferencing tools or via phone calls. And things like that is helping to enhance care in areas that would ordinarily not have access to care.
Right, thank you. But one of the things which is confusing people is they conflate AI to EHR, and it's mostly in terms of capturing data. A lot of people have not spoken about issues like electronic decision support system for diagnosis and management. So why is there that disconnect despite so much of advances in AI?
So I think the challenge also lies in the fact that the electronic medical record systems, when they were initially developed and implemented, they were developed for a different reason. A lot of them focused on really developing a tool that can be utilized for billing. And it wasn't really created to provide optimal patient care. So what we find is that we are building multiple different things on top of these EHR systems for it to be able to provide to us what we want it to do. And then it becomes fragmented, multiple different things, multiple clicks to be able to get information for your patients. And now as we're thinking about using AI tools as well, there's like multiple areas where the data goes. And we have a lot of unstructured data in the EHR that when it's time to leverage it for prediction, it becomes even more challenging. And one thing I think for me, moving into the future, we talk a lot about making sure that AI fits into our current workflows. But I think we're at that point where we need to reimagine what the current workflow is. Is that current workflow efficient? Should we be documenting lots of text and unstructured data into the patient chart that we know will become a challenge later for us to analyze? Or should this data be structured at the point where you're seeing the patient? And maybe we need to reimagine what the EHR should look like.
Good that you have brought out some of the inherent challenges. I think we are at the midpoint of this discussion. Maybe I'll open it to the audience if they have any question, and then I'll come back to you. We have a very small audience, but hopefully they are more engaged. And Amy, you want to ask a question? Yeah. No.
Thanks. Where workforce is limited, we're compounding the issue by our specialization and super specialization. What are the opportunities to start again? We've created this problem, this beast of silos, and we've exported this beast to LMIC settings where there's less workforce. How do we fix that?
Maybe you want.
Yes. That's a great point. We need a balanced approach. And as you alluded to, in many low and middle income settings, and I've actually seen this play out in Ghana when we had a health fair in a village, and we met a midwife who delivers all the babies in the community. There's no primary care provider. She's it. She's everything, right? So we're starting to think about how we can train midwives beyond delivering babies and maternal health care to also deliver primary care, but she can't do it alone. So how do you train community health workers, lay members of the community to support the midwife because there are no physicians around, but how do you also support them with the appropriate tools and leverage telehealth as well? So how does she connect with a cardiologist? How do we empower and equip her with a point of care ultrasound device? That's one of the programs we're doing in Ghana right now. We got a small grant from Johnson & Johnson to train midwives to use point of care and portable ultrasound devices to screen for peripartum cardiomyopathy. So if you do identify any abnormalities, how do you refer to the nearest teaching hospital? So you highlight an important challenge, which is that the model that works in many high-income countries may not be appropriate, but how do we learn? And the other thing is that I think innovation happens both ways. Sometimes we like to think that we have all the answers in, high-income countries, and we're just going to and transport these solutions. But I'll tell you, one of the trials that we did in Ghana was a home blood pressure monitoring intervention. We trained nurses to manage blood pressure. We gave participants a blood pressure device, and they also downloaded a mobile health application. And this was during the COVID-19 pandemic, when there was a lockdown and no one was allowed to go to the clinic. Participants in our trial still maintained blood pressure control. And so we decided, well, if it works in Ghana, why can't it work in Baltimore? And so we actually designed a similar trial in Baltimore that we're conducting right now. So I think you've highlighted issues in terms of the differences in the structure, but also a tailored approach.
Well, there's a question there.
Hello. Yeah, I'm Dr. Karpati from Columbus, Ohio. Thank you for the wonderful discussion. It is true that workforce is changed. I am at the grassroots level, and I do see that there is a attrition of workforce since COVID. And the big difference that I see is the work ethics is different. I call them the COVID trained people, either doctors or nurses. They are trained not with the patient, they are trained with technology. That, and also the work ethics is different. They're more dependent on technology than taking care of patients. Yes, we can give all blood pressure monitors to monitor blood pressure, but who's going to take care of their anxiety when the blood pressure is up and down? So that difference, is there any studies that show the COVID graduates versus the old?
Excellent question. I think we'll take this.
Okay, I can try to take that one. I am not aware of any studies that has looked at those who graduated during the pandemic and compared them to those who graduated at a different time and whether this impacts the care that they provide. But there are studies that have looked at the impact of technology on how we take care of patients, on things like empathy, how the patient responds to us. And what you will be surprised about is that patients actually like technology. And they've actually been given a lot of positive reviews about the use of technology and how that impacts their care. Sometimes also having access to technology and tools empowers the patients. Patients sometimes are able to spend time maybe looking up their diagnosis, conversing with a lot of new large language models, and we find that many of them are excited to have that opportunity to discuss with a physician that is willing to be open to consider these things, an alternative diagnosis and differential diagnosis. As much as we like to believe the fact that we are always right as physicians, the truth is that we're not infallible. And what we currently do is not perfect. So if there's something that we can leverage to improve the care that we're providing to our patients, then we should take it. But we have to look at this in two different ways. We do know that technology in the past has had a negative impact on patient care. So for instance, the era of digital technologies and using EHR, we were spending more time in front of the computer typing, looking at the computer as opposed to engaging with your patient. You spend like 5-10 minutes with them, but you have several minutes and hours to chart, and when you get back home, that was actually a problem. But now that we are moving into the AI era, we are trying to basically get that time back, where you don't have to spend as much time in front of the computer typing, because now an AI agent can type for you. All you have to do is speak and engage with the patient, and something is listening in the background like a scribe, and then your notes get typed for you. So you can reclaim that time to be able to give that patient the attention that they need and have more empathy. Also, there's been examples from the EHR in basket, where patients will send messages to their physicians and expect a response. Because of how busy we are, most times when physicians respond, it's like 1 or 2 liners. You're fine, it's negative, your result was okay. But when an AI responds, it's like, I'm so sorry, ma'am, to hear that you're feeling this bad. I spent time going over your results, and what I have found is that even though it shows this and that, your results were actually normal, and I am not concerned. But if you continue to feel bad, we can schedule an appointment for you to come back. This is completely AI generated, and patients believe that these AI generated responses have more empathy, and they actually rate those interactions much higher than interactions that come directly from their physicians. So I think that we can learn, take some good things from technology and leave the bad.
I'll just add that for all the COVID-19 graduates, we need them, right? We have a shortage of healthcare professionals. We need them in the healthcare system. But this is where leadership plays a role, right? So if you are in a practice or you notice this trend that there are particular members of the healthcare team that don't have that empathy or there's that disconnect, this is where, because when you start, you have what, preceptors. If you notice that maybe a year after, maybe there's a sort of training that has to happen where you find someone who's more experienced and have that one-to-one relationship in addition to the, the points that Dr. Demi made. But I feel like we need them. They're here to stay. But how do we retrain them to address some of these issues as well? And this is where leadership plays a role.
I totally agree with that. But to compound that, during COVID, about 1/3 of experienced staff, either they retired or they were let go, and they have not come back to healthcare industry. So even to find leaders to train with that empathy is kind of a little difficult.
So I think that's the reason why we are discussing this today. But I have a question. I think we all are agreed now that we require a health system redesign, something to address some of the challenges that people have gone away and they're not coming back. And therefore, there are two issues people have been talking about. One is task shifting, task sharing, decentralized care. They come with their own challenges, but also they provide us with tremendous opportunities. Now, the question is, how do you reduce the insecurity of a higher level healthcare provider because they think that their job is being taken away by somebody at lower level? How do we convince patients that when we shift task, it doesn't mean that we are giving them inferior quality care? So these are some of the challenges that we face now. What are the solutions that you are thinking of?
I'll start by saying we have to acknowledge that our healthcare system as designed right now is not convenient. It's not, right? If someone has hypertension, we ask a lot of them to take time off work, drive for a 15-minute visit, go back to work, find childcare. So we have to reimagine what does it look like to manage some of these chronic conditions in the convenience of their homes or their workplaces, right? Most of us spend more than about 8 hours at work, right? So what does it look like to reimagine healthcare in the places that we live, learn, work, pray, including community-based settings? And to your point about task shifting, task sharing, I like to say, you know what? There's enough cardiovascular disease to go around, right? That's a reality. Physicians alone, cardiologists cannot manage the burden of cardiovascular disease. And nurses cannot do it alone, neither can pharmacists. So what we do need is team-based care. There are a lot of trials that have demonstrated that team-based care improves health outcomes. But we need the right incentives, right? We need the right policy reforms to allow team-based care to happen. And what I think makes a difference in our trial is that we engage physicians in the training of nurses. We tell them, this is what we're trying to do. We want you to focus on the more complex cases of complicated hypertension and other comorbidities, but for simple hypertension, that's all they have, no renal disease, no diabetes. Would you come along with us in training nurses to use a standardized protocol to manage hypertension and also work with you? We are not taking, no one's taking over your role. They are supporting to improve health outcomes. And so that is the approach that we found to be effective when we engage our physician colleagues in the training process as well.
I agree with you. I think we require a nomenclature change. Don't call it task shifting, call it task sharing. And that fits very well with the team-based care. I think there was a question there.
That's what one point that I want to
Can you
talk about. The, the work that the nurses can do to make prevention, to take the message. But the nurses in United States, or you say United Kingdom, it's not the same level as maybe in my country, it's in Argentina or South America. The level is very under. And I think we must make more instruction to give them some to take the message to prevention to what can do the nurses in all the system. I think it's very important for this.
So I completely agree with your points, and I think what you're raising is the fact that the skill level may be different in different countries, and that maybe the things that a nurse is empowered and able to do in the United States or in higher income countries might not be the same in lower income countries where maybe the education that the nurse has received is different, or maybe this is someone that has received a nursing assistant type education, like a midwife, is not really equivalent to a nurse, and you're completely right. I think this is why, as we are talking about reimagining the health system and how we do things, we also have to understand that solutions cannot be widely or generalizable. Solutions have to fit the context in which we are trying to deploy, that specific intervention. So I think that in resource-limited settings where, there's a limited number of specialists, limited people or healthcare workforce who are trained, the solutions there have to be different. And I completely agree with task sharing is something that we also employed in one of the studies that I led in Nigeria. But what we did is we also made sure that we provided support to those staff that will be doing this. So not to bring the conversation back to technology, but if there's technological tools that we can leverage, we find out that this is helpful. And in that study, I would just kind of give you a practical example, very similar to what Yvonne is doing in Ghana. We wanted to develop or evaluate a tool that could help them readily identify peripartum cardiomyopathy, which is a condition that is unfortunately very common in Nigeria, about 1 in 100 cases associated with high mortality, almost 40%. And the challenge is that it's difficult for us to identify which pregnant woman has heart failure and which one doesn't, because there's a lot of overlap in the symptoms. So there's this technology we evaluated, which is a digital stethoscope that can record the heart's electrical activity as well as the heart sounds, and then it uses artificial intelligence to make a prediction. So we don't have to rely on that healthcare provider to hear the heart sound and know that there's a murmur. It will tell you that a structural murmur is present. All you have to do is place it on the chest and actually allow it to record. And in the case of peripartum cardiomyopathy, it would give you a prediction. There's a high likelihood that this patient has heart failure, and then they can identify which of these pregnant women with symptoms and leg swelling should we refer to see the cardiologist, should we refer to make sure that the OB is aware, and then we can do additional testing. Given limited resources, not all of these women get to see the OB, not all of these women get to get an echocardiogram, but that way we can identify them early. And the training we provided was so straightforward that anyone, even without high school education, can use this digital stethoscope and place it on the chest for a 15-second recording. Of course, we had to train them, what does it look like when it's positive or negative? But the tool is also very intuitive. It's like red and green. When it's green, good. When it's red, bad. So then you know that you have to refer. So those things can also help in environments where there isn't sufficient skill to be able to make decisions.
So, right, that segues into my next question. So, how do you actually, what are the challenges? You mentioned some of the challenges of how we integrate AI into routine healthcare. My question is, how do you make it equitable, accessible? How do we address the human rights issue? Because it actually leads, while we think that it is democratic, it can actually be inequitable. How are we going to address that question?
So that's an excellent question, and I think that one that is very much on our minds as we start to think about the future of healthcare using technology and using AI. And there's a lot of effort now to start developing guiding principles or core principles for deploying tools like this. And, efforts to ensure that AI or technology is equitable is something that we call responsible artificial intelligence, or another term that has been used is tequity. So ensuring that there's equity when it comes to implementing technology for healthcare, because we know that health equity is a huge issue, not just in resource-limited settings, even in high-income countries like in the United States. We know that health equity is a huge, huge contributor to adverse outcomes. There's also an economic impact for health equity. So I always like to say this, that addressing health equity is not just a moral issue because we know that it's the right thing to do. There's also an economic imperative to address health equity. based on the 2006 estimates that the American Public Health Association evaluated, what they found was that if we completely eliminated health disparities in the United States, we will save healthcare costs over $230 billion. So it is a huge, huge imperative for us to make sure that when we're rolling out these tools, we don't essentially worsen health disparities. And there's been different things that we need to consider. As we are rolling out tools, does it work well in all patient populations? How do we know this? We have to validate these technologies. The fact that something new is out doesn't mean that it's fit for purpose and everyone should use it or everyone can use it. So we have to test it in the different patient populations. So we cannot overemphasize the importance of validation. Different environments, different patients. Does it work there? Will it work there? And will the healthcare providers use it? Is it user-friendly, or is this more of a burden for them? Just like, the history of the EHR. We thought it was going to change things, but then people ended up hating the EHR because it's like 10,000 clicks to actually do what you need to do and care for your patients. And then we are realizing that in retrospect after we already rolled it out. So I think that with newer technologies, we have to be a little bit cautious about that. We have to make sure that it fits. We have to make sure that it actually addresses important clinical outcomes, because we can test it and publish nice fancy papers, but then when you deploy it, does it actually change outcomes for patients? Are we getting them earlier to care, and are we improving their lifespan, reducing the likelihood that someone will die from a condition? And the only way we know this is by evaluating them in the context of either a clinical trial or a prospective study.
Right, thank you very much. I think we are at almost the end of the panel. I would like to summarize by saying three things. Number one is science is reductionist. So AI-based solutions are reductionist. But you are saying that the solutions have to be holistic. We have to take the complete patient into consideration. The second thing that reminds me is of an author by name Alvin Toffler. Alvin Toffler, he was a great author in 1970s, 60s, 70s. He wrote a book called Future Shock. And he said the most successful man, but I will say human being, most successful human being of the 20th century is one who learns, unlearns, and relearns. So what this panel has suggested is we have to unlearn some of the things, we have to relearn, and probably go back to some of the things we knew in the past. The last thing I want to say is we have had a very small number of people here, but I want to remind of a lady by name Margaret Mead, a cultural anthropologist, who says, don't underestimate what a small group of people can do. You people will change the world. And I think we can write this up. I was telling to Lana that we should write this up as a perspective. And I would like to involve everybody who is here, because it's a small group, who want to be part of that group. Let's write it up and give it as a perspective. Before we leave, 30 seconds, what do you want to say?
I'll just say that team-based care is the way to go.
Okay.
Healthcare is a team sport. We should value each member of the team and support and reward them accordingly.
Right, thank you.
I would say that I am excited about what the future of cardiology holds, and that I believe technology and artificial intelligence really will improve what we currently do and the care we provide to our patients.
So let's give a loud applause for all of us. Thank you.